Low-dose naltrexone is FDA approved at 50 milligrams to 150 milligrams or so to treat addiction to alcohol, addiction to opiates. And what it does is it knocks down the urges that addicts have and reduces cravings. So naltrexone is the same class of drug as Narcan, which many people have heard. So if someone's having an overdose, they get Narcan up their nostrils, naloxone, and they start breathing again.
Hey everybody, it's Dr. Rimka, and I am super excited. We have a special guest today. I have been trying to schedule with Galyn Forster, licensed professional counselor for quite a bit of time here. He and I spoke months ago, and I was so intrigued and so excited and absolutely fascinated with what he had to say with how mental health has a lever we could be pulling that I didn't know about. And we're going to get to that. And it's actually a medication. And I know that might sound weird coming from the, super anti-big pharma, all natural holistic doc, but believe it or not, sometimes the pharmaceutical industry has stumbled across something that can be very helpful. And this is actually called low-dose naltrexone, LDN for short. Many of you might be on it for like Hashimoto's or MS. And I see a lot of those patients. And over the years, it's a drug I've come to like. And I know, but I had no idea the scope of what it can do for brain disorders and mental health issues until I met Galyn Forster from a website that does research and educational information on LDN called ldnresearchtrust.org. So he's a licensed therapist of 30 years. He deals with anxiety, depression, and trauma using some really cool techniques that I love, EMDR, and a special style of neurofeedback called Lens. So, Galyn, thank you so much for joining me.
Thanks for inviting me, Stephanie. I'm a trauma therapist in Eugene, Oregon, and I was introduced to low-dose naltrexone in 2008 at a conference by Ulrich Lanius, and he was using it with severely traumatized dissociative patients who were not able to stay present enough to do their own trauma therapy. And with naltrexone on board, they were able to stay present. Because what naltrexone does is it disrupts dissociation, like flashbacks, just totally zoning out, leaving the room. And since then, I've been really interested in this medication and have started, shortly after started trying to find doctors to prescribe it. It wasn't very successful initially, but eventually got some traction. And one of the things I should say before we get going is that, I'm not a medical doctor. This is not medical advice, even though this is medically relevant, it's not a substitute for medical advice. I'm about the farthest thing from a science major. It's kind of odd that I'm the person kind of sharing some of this information.
Well, that really blew my mind. So a lot of people, so let's just preface it. Like, why don't you explain what LDN is? And it's typically, how it's typically used is kind of in the autoimmune and inflammation disorder. Because when you were the first person to ever tell me, oh, it helps stop dissociation, I said, what? That was mind-blowing to me. So if anybody doesn't really know, so then we probably need to explain, well, what's some of dissociation? What does that look like? But so people who are struggling with dissociation that's going on post-trauma, and a lot of people don't realize it. Honestly, I see a lot of people misdiagnosed for ADHD that come into my office, and it's really dissociation. I've had a hard time at first telling, was I looking at seizures or dissociation? It's taken, I do QEEG brain maps. I'm like, they don't have ADHD. I don't see seizures. Something's not right here. And they're just misdiagnosed, right? Undiagnosed basically as well. So why don't you explain what is LDN and its basic mechanism, and go into this, how it helps trauma and dissociation patients be able to be present and get therapy and healing. It's so promising and so exciting to me.
Okay, so low dose naltrexone is just a very low dose of naltrexone. Naltrexone is FDA approved at 50 milligrams to 150 milligrams or so to treat addiction to alcohol, addiction to opiates. And what it does is it knocks down the urges that addicts have and reduces cravings. So naltrexone is the same class of drug as Narcan, which many people have heard. So if someone's having an overdose, they get Narcan up their nostrils, naloxone, and they start breathing again. So naltrexone is an opiate, classed as an opiate antagonist. And what that means is it binds with the same receptors on neurons and other cells, but you don't get the same response as you do from morphine, heroin, fentanyl. So when someone's given naloxone, Narcan, or naltrexone, the antagonist, knocks the other drug off the receptor, and you have a neutral response. And the person, if they've stopped breathing from an overdose, starts breathing again. So naltrexone is an opiate antagonist, and that means it doesn't do the same thing as agonists. So heroin's an agonist, morphine's an agonist. It does what your body has natural opiates that cause euphoria, reduce pain, are involved in just about everything going on in the body, really, because the opioid system is maybe one of the oldest neurotransmitter system to evolve in the body. And so it touches everything. It touches the cannabinoid system. It touches dopamine. It interacts with everything else. So it's a real basic part of who we are. So with naltrexone, at 50 milligrams or more, it's kind of like a blanket on the opioid system. It just hits it very hard, and it has a dramatic effect on it. Low dose, so 50 milligrams versus low dose, which is usually something between 3 to 4.5, 6 milligrams. That's in the low dose range. It used to be in the low dose world that anything above 4.5, people that were hardcore low dose naltrexone people would say, well, that's not low dose if it's lower than that. But more recently, we're opening our thinking up to adjusting it for whatever's helpful. Some people respond to very low doses. So with low dose, what happens is, okay, let me back up just a little bit. Also, what's important to recognize with naltrexone is it has a 4 to 6 hour half-life. That means there's half of much in your blood at the end of 4 or 5 hours. And so let's see what I want to say about that. Naloxone is about 45 minutes. So what's relevant with naltrexone, it's around for about 4 hours. So with low dose, we're just subtly affecting the opioid system. We're not antagonizing the whole system. We're just binding with a few of the receptors by comparison. And so what happens is we end up having a subtle regulating effect on the opioid system, but it's not just the opioid system that's affected. It also affects the immune system, and it directly antagonizes something called toll-like receptors. In particular, toll-like receptor 4 is very involved in the immune system and inflammation and excess inflammation. You may have heard some reference to toll-like receptor 4 if you've done any study of the cytokine storm involved with COVID-19. there's this, the body kind of goes crazy at times with inflammation. So what happens with naltrexone is quiets down that excess inflammation in the system. And what we recognize now with virtually all somatic medical disorders, mental health disorders, inflammation plays a big role. And that's part of why low-dose naltrexone is really helpful, because it subtly brings the body back into a regulated state instead of having this overreactive kind of defensive response when the immune system overreacts.
Yeah. Let me say this. Let me just go with, so naltrexone in this high dose. So for the listener might be like, okay, you said a lot of words that sound the same. In this high dose, 50 to 100, say, milligrams, right? It's used to treat, how I understood it, and correct me if I'm wrong, right? Alcoholics and drug addicts, basically. So they take it all the time, and then it blocks all the receptors, and they can't feel the high from the alcohol and the drugs. Right? Is that what it is? They don't get the reward.
It blocks the buzz.
Yeah, it blocks it so much. As where when we do the low dose, and there's even ultra low dose, like you said, it can be really, really small doses. You're not doing this blanket thing. It's just a little bit of them are kind of done. And by how I teach it to my patients, I refer to it like as a hormetic stress, like exercise or sauna, like fasting. We're stressing the system out a little bit, but not too much. And then it has a really big like healing response after. It says, oh, I didn't really like that, so I need to make more. I need to do something better after. And by filling up a little bit of these opioid receptors, right? You make more later. So is that that's the difference? Because with naltrexone, if you do it in 50 or 100 milligrams, does that same thing happen?
I don't believe the same thing happens. So with an intermittent treatment with naltrexone, where you have a small dose, or it could happen perhaps if you had 50 milligrams, but then you didn't take it for a couple of days, that might happen. Okay. But so the early understanding of low-dose naltrexone was that the idea was you take it in the evening, it triggers a reaction in the opioid system that causes the opioid system to produce more endorphins. And so it upregulates endorphin production. What wasn't talked about as much was it also upregulates the number of endorphin receptors at the same time. And part of what's important there is that there be an intermittent binding of the receptors. Well, by definition, because it's such a low dose, it's considered an intermittent intervention. Dr. Dalgleish, one of the leading researchers on using naltrexone for low-dose naltrexone for cancer, described it that way, that it's just by being such a low dose, it is an intermittent.
Okay.
Intermittent
so let me say this. So like, you probably come from the same thinking, but let me just say for the listener, I've been trained and think more of the postulate that, you know, the brain equals behavior. And if the healthier I get the brain, the healthier behaviors, right? Because it can assess information coming in, make better decisions, come from an integrated aspect, and then have more of a better motor output, right? Good brain, good behavior. Yep. Bad brain, bad behavior, right? We make it real simple. And there's a lot that goes into what's dealing with the structure and function of the brain. And one word you keyed in on was inflammation. And inflammation is a huge part of a lot of things that get diagnosed as mental illness, where actually it's really just a brain inflammatory disorder of some sort. And it could be coming from traumatic brain injury, an actual concussive moment, flying through, you know, a windshield of a car, or an inflammatory problem from a long-standing gut issue, an infection, dysbiosis that's causing leaky gut to leaky blood-brain barrier, right? a host of pathogens, right? This is mold and Lyme and strep and staph, all kinds of things can cause radical changes in mental health and psychiatric illness. That's like, that really talk therapy isn't the solution. We can see there's a very deep physiological cause to this. And it's why so many multi-system complex disorders such as chronic fatigue syndrome, right? Fibromyalgia, Lyme, mold, right? Other vector-borne illnesses, other long haul illnesses, PANDAS, let's say, there's always depression and anxiety related, right? Because there's so much systemic inflammation. And I've been amazed at what LDN, like how LDN comes in and does, it's in so many ways with lowering inflammation everywhere and lowering the cytokine storm, going with a toll like factor receptors as well as interleukin 6 and other things. It's really like a smart, like to me, I tell them it's kind of like a smart drug. It kind of knows what to do and when not to do. It doesn't just push down or push up. Somehow it modulates the immune system. So the immune system is like, oh, so it can know itself better, you know, and how that's playing in on the brain and how it's helping alleviate, you know, chronic brain inflammation and how that has a whole cascade of effects. I don't think any of us fully know, but I know it makes total sense that it's working to do this in a long-term fashion and not just kind of covering up, like sprinkling, you know, Prozac or sertraline, you know, onto the brain, where I'm like, that's not actually smart or intelligent.
I think a really good way of framing it is, this is regulation versus replacement. This is something that just tweaks the system, and then things come in line. It stops for overreacting. And so many of the, you know, psychotropic drugs, the pharmaceutical treatments are about replacing function. And you think about, I've got a client with rheumatoid arthritis and lupus, diagnosed at 15, and she's 40 now. When she started taking low-dose naltrexone, she stopped having flare-ups. And what she described is low-dose naltrexones worked better for her than any of the steroids. Which was, that's amazing. And it's a subtle intervention instead of this really big, it's like using a little jeweler's hammer instead of a sledgehammer to do something.
Yeah, to me, it's like it is, it's regulation. It helps the system modulate itself in a better manner. It helps it go, oh, like that's what I'm doing. And it can, you know, it's a smart drug is how I kind of tell people. They're used to iPhone. I'm like, well, it's LDN. And it took me years to finally go, for me, it just was like, is this going to interfere with neurofeedback? You know, I said, no. I said, we can start, that doesn't do anything. And then I had to see it over and over again, like, this is helping, wait, what is this stuff doing? And with Hashimoto's and MS, I was more into those diagnoses. And then eventually it became, wait a minute, this has a place in autism, because I'm looking at the gut and what wait a minute, then, oh, look, there is actually a lot of people using it for that. This has a place with Crohn's. I have all these people. It just was more and more. And then it made sense that even though many people are not using this as first line for anxiety or depression or trauma, they're thinking of all these other drugs, because I would speculate those other drugs make a lot more money, and this isn't not doing that. So no pharma reps tell anybody about LDN, so no physicians know about it. So why don't you talk about that? Yeah, tell them why, like, because that's what people say, well, if it's so good, why doesn't my doctor know about it?
Well, the first response you often get from a physician is, well, it can't be true. It helps, you say it does, it helps all these different disorders. That can't be true. It must be snake oil. Well, actually, sea snake oil actually has anti-inflammatory properties, but we have a different understanding for what snake oil is. But so they think, well, it can't be true, but these all have a kind of a relationship. They're all about the immune system. And so, okay, I lost my way a little bit here.
That's okay. Well, like why don't doctors know about it, right?
Oh,
The
okay, yeah.
pharmaceutical, like, right? Why don't they say, oh, okay, one, they think,
Nobody,
well, it does too much, it can't be true. But
yeah,
and then they also aren't being told about it.
nobody owns it. This is an orphan drug that nobody has a patent on. They can't have a patent on it. And so the drug companies aren't interested. They
Right.
can't make a big killing. And if you think about it, it's going to compete with incredibly expensive medications. Yeah, so some of your treatments for MS are $50,000 a shot.
Right.
Well, this is maybe 50 cents a shot.
Yeah.
So
It's very affordable. It's usually about 30, 40 bucks a month. People do have to pay out of pocket, I think almost all the time.
usually,
Yeah, but it's very affordable in terms of things coming from a compounding pharmacy. For those of you who are interested, I will put in the show notes a great website. I give this website to all my patients. This is how I found Galyn, and he's actually an author in one of the chapters of the definitive book. It's called the LDN book, volume 2, correct?
correct.
And he is an author of a chapter on mental health, correct? PTSD, I think.
Yeah, PTSD.
Right, and how to use LDN with PTSD. So that book is kind of like, I don't know, the Bible of LDN maybe right now.
I don't know if I'd go that far, but yeah, it's probably the most reliable source at this point.
And is it for like a layperson or clinicians or both?
It's for both. There's probably, well, there's quite a bit of variation from chapter to chapter probably, but I think it's written in a way that someone with a bit of an education is going to do okay. Some chapters really get into the weeds. In the volume 1 on thyroid issues, that gets pretty deep into thyroid issues, but most of the chapters are pretty accessible.
Okay, so I'll have that down there, you guys. It's a great, it's ldnresearchtrust.org. I'll put it down there. That's not Galyn's website. It is a large organization. It's a nonprofit. There's resources on how to find a doctor to prescribe this, an LDN specialist. They have conferences, webinars you can buy, training, but all kinds of free resources and free videos and dosing guidelines, and that you can print out for yourself and that you can take to your doctor and be like, so here, I've done some research. What do you think? And it's all done for them, short and sweet. And I've had quite a bit of success, and I think you have too, working with the prescribing physicians, their psychiatrists or their PCP, to say, hey, why don't you talk to them about this and how we could work this into the plan? And I've pretty much had almost everybody very open, and some physicians incredibly excited, and they've gotten trained and they've made it a part of their practice, or they were already prescribing it, but they thought of it like I did. Hashimoto's, MS, Crohn's, inflammation. They didn't think of the person with severe anxiety or dissociation or PTSD or OCD, tics. Autism. They didn't think of them as an LDN candidate, right? So it kind of helped educate. I'm like, look, why don't you look at it? And they're like, oh, really? And then just any little time you can make one of us a little better in whatever field we're doing, you've done a lot, because who knows how many other patients, I help. So you've been able, you talk to the psychiatrist, right? And get them to help work with you.
Yes, once in a while. I usually have better luck with regular MDs, but there are some psychiatrists that are open to thinking out of the box, and some of them are really locked into just staying in the box.
It's an interesting field, isn't it? That field is really stuck. I'm like, wow.
Stuck, and I think it's really exciting what's happening around psychedelics that may be kind of opening people's minds up a little bit more in the psychiatric world, not because they're taking them, although maybe they ought to try. But yeah, so let me say something. Dissociation is involved in, it's probably overstepping, but I don't think it is to say it's involved in just about not all, but any trauma-related mental health issue. Dissociation is probably going to be showing up in one way or another. derealization or depersonalization, feeling like you're not really a person or feeling like things aren't real around you. That's one version of dissociation. Another one would be flashbacks. So when people think of flashbacks, they think of a veteran from a military veteran who comes back and hears a backfire in a car and then feels like he's back in the battlefield again, right in the middle of it. That's kind of an extreme form of dissociation. But people have dissociation from all kinds of trauma. Your rape survivors will have dissociation, and but dissociation or a flashback. But dissociation can be just spacing out. It doesn't have to all be pathological, but a lot of it is. But you can have emotional flashbacks. That is, you can be in an argument with your partner, and then you essentially get triggered. Something reminds you from your childhood or how you were helpless or how you just don't want to be a loser again. And now you're fighting for your life. And the next day, none of this seems important anymore. Why was I so upset? Well, you can have an emotional flashback where you've got old emotion piling on to your current experience. And there's no marker that it really isn't about what's going on right now, but it really magnifies what it feels like. So now you're fighting for your life. I think we go in and out of trance all the time. Some of it's just routine, and some of it is trauma driven. And naltrexone disrupts those trances so that it's much harder to stay stuck in that. You get to maintain or have the big picture. You can see the trees instead of just being stuck in the trees.
And do you know why it is? Does anybody have this figured out? Like why, how it's doing it?
Yeah, the way it's disrupting dissociation's mediated largely, I guess I should say it's the opioid system plays a large role in dissociation. So the more extreme example would be, so you're walking along in the Serengeti and a lion jumps on you, and it's getting ready for dinner and you're not enjoying this, and your body in that kind of situation is flooded with natural opioids. It's as if you've just had a big shot of heroin or something, so you're not there anymore. You're not feeling anything. You're really weak. Maybe you vacate your bowels, but you don't care anymore even. And you're not feeling the pain because you're flooded with opiates. So that's an extreme example of dissociation. And it's being done. It's adaptive. So another example, Peter Levine uses this example in talking about our trauma response. A predator can jump on an antelope, knock it down, and it looks like it's dead. So maybe the cheetah goes off and finds its cubs to teach it how to kill. If it takes too long, the opiates kind of clear from its system. It gets up, shakes it off, and it rejoins the herd. So it's adaptive. It's had an adaptive function to help save the creature. Either it doesn't have to be in as much pain, or it looks like it's dead. We call it, everyone's heard of playing possum. When a possum's playing possum, it's not playing. It's actually probably just flooded with opiates because it's really scared. It couldn't escape. And so it's acting like it's dead. And it fools you if you don't know what's going on. So so most of the dissociation that people are experiencing isn't so extreme, but it's getting triggered. So that's about unfinished business from your past. So the memory is in the system, something happens in the present moment, and then you get triggered and it's like that's happening again, but you don't recognize in the moment that you are overreacting. You might notice that, but you don't know why. So I feel like I'm not being really clear
Well,
here.
you are. No, I mean, it's good so people can understand, I think, because there's a big range of it.
Yeah.
You know, we've gone through what the extreme would look like and how, and I'm sure you've seen DID, you know, clients. I have too. They're coming in like for neurofeedback, and I work with their psychologist who's a DID specialist. So I'm like, okay, I had to be talked into it at first. That's multiple personality. We don't call it that anymore, you guys, but so it's dissociative identity disorder. So I've had these clients, and that even against me, I was like, no, no, no. And the psychologist like, no, but they really want you. Like they trust you. So we need you to do the neurofeedback. I'm like, well, if you can handle everything else. And so they kind of taught me over the years, you know, specialists like, you actually can do this. So let's just teach you. I'm like, okay, you know, like as long as we work together, and I'm trying to stabilize a severe, you know, panic, right? I'm not trying to get rid of the dissociation per se. I'm bringing the anxiety, the arousal down, and letting the, you know, talk therapists handle the part that and it makes the whole thing work better together, whether usually they're trying to like integrate in some way. Now that's the extreme. Now we have this other where you described PTSD. And I would explain with them, like, let me go back, like, it's a good thing. Like if that was happening to me when I was 5 years old, I would have hoped I would have checked out, numbed out, and created an altar as well. Like, you know, if I think I'm a woman. I think about sometimes if something were to happen, I hope that's what happens to me. And I hope I don't know what's, you know, like, why would I want to live through some of these things that could happen, unfortunately?
And most trauma survivors don't develop DID, but many trauma survivors have that memory, those protective responses stuck in their system, and they were never able to really complete the attempts to protect themselves or escape. So they have the memory of being trapped or alone, no help, locked in their system.
Yeah. And it's when it's locked, it's easy to kind of agitate it like an open wound when salt hits it. You're like, ow, ow. And people kind of gets like, that's what it's like. It never quite heals. And when they put it in the salt water, it burns, or the alcohol touches. Wow, that really hurts. So let me ask this, because I want to get into the difference of the dosing.
Yeah.
So I've had plenty of patients that are on LDN. They take it at night before they go to bed, and they're on it for Hashimoto's, let's say, very common. And they're still got a lot of trauma, and they're got PTSD still, right? And so we're working on that with neurofeedback and chemistry and stuff like that. Why didn't the nighttime LDN seem to help with the daytime PTSD? So this is when you explained something that I was like, that's a total different mind-blowing game changer.
It really is to treat mental health issues effectively with low-dose naltrexone. It needs to be taken differently than for all these other disorders. The immune system, 1 time a day in the evening, cancer, IBS, all these other issues, 1 time a day is adequate. Doesn't matter that much whether it's morning, evening. But with mental health issues, we're directly trying to disrupt dissociation, that mild trance that most people wouldn't even call it trance. We're trying to disrupt that in the moment. And remember, I mentioned earlier, low-dose naltrexone's half-life is 4 to 6 hours. And it appears that it's most effective in disrupting dissociation when the first half, when it's in that half-life range. The longer it's out of your system, the less effective it is. So the most important thing for treating mental health issues to remember is it must be taken during the daytime, because that's when we're living most of our life. If you take it in the evening, you may sleep better. About 50% of people, at least, I think, sleep better on it. And there was a survey of about 800 people on LDNscience.org that 50% slept better, 50% it didn't make much of a difference. There are some people that get energy from it when they first start taking it, but that's a small percentage. So it has to be taken during the daytime. Otherwise, you're kind of wasting that benefit of disrupting dissociation at night. Then it also needs to be taken multiple times. You only take it one, so you're going to have 4 to 6 really good hours in your day, but then it's going to start wearing off. And if you took it in the morning, by the end of the day, when the kids are coming home or your partner and things have been stressful all day, it's 2 half-lives later. Maybe you've got the equivalent of 1 milligram of naltrexone in your bloodstream, and it's not going to do the same job. An example, I've had a guy I was working with, had a fairly extensive trauma history, a resilient person, a lot of gut issues, and conventional medicine wasn't effective treating the gut. So he would take low-dose naltrexone first thing in the morning. He'd be fine. He was a smoker, but not a heavy smoker. But in the morning, if he took naltrexone in the morning, he'd light a cigarette up, take 1 puff, and put it out. It didn't taste good.
Right. Let me ask about the dosing, since we're talking about it. Like, it's a little bit different, right? Are they taking this big heavy dose at night? Well, it's not really heavy, but 4.5 milligrams, let's say at night. Are they taking 4.5 milligrams multiple times throughout the day, or is it different?
Yeah, it's the same. It's the full dose multiple times. Although, you can tweak it different ways. You might take 4 milligrams or 5 milligrams. So the dosing that Ulrich Lennius and I've this seems to be the most effective dose is 0.06 milligrams per kilogram. That amounts to about between 3 to 6 milligrams, depending how big you are. Someone bigger needs a larger dose. Okay. Some people get the benefit at a much lower dose, but in general, most people respond most robustly to the full 0.06 milligrams per kilogram dose. And that after 4 to 6 hours, that's wearing pretty thin. So this guy, he would, if he had taken, so later in the day, if he just took 1 dose in the morning, in the evening, he'll smoke the whole cigarette because he goes back into the cigarette smoking trance. Or drinking, he didn't have a big drinking issue, but he would drink too much. So in the evening, if he hadn't taken it, if he only took it in the morning, it didn't help with his over drinking. If he took low-dose naltrexone in the evening, later afternoon, he'd drink 1 or 2 drinks and that's enough. So, and that was because it wasn't strong in his system. I think of one woman I was working with who came to me because she had alopecia. All her hair fell out, and that was the favorite thing she had about herself. And she was a basket case. She would have 2-hour crying jags at work. She couldn't handle herself. Anything goes wrong, she's falling apart. She started low-dose naltrexone. She was even. She was someone that you could go to for problems at work. It really.
How many times a day was she taking it?
She was taking it 2 times a day or more. She would take it PRN. So as needed. So if she had a big meeting coming up, she would take it half an hour before the meeting. So it's full strength. What a person can also do is to take a half a dose. Say you took 4 milligrams. And then 4 hours later, okay, you've got 2 milligrams equivalent in your bloodstream. Well, you want to bring it back up to 4 milligrams, take 2 milligrams, and you're good for another 4 hours or so.
Wow. And we always hear LDN is very individualized. This is like so individualized, right? It's like then you really are empowering that person to check in with their own feedback system. And I'm assuming probably prescribed in 1 milligram, they can adjust it a little bit. Like, I know you want to work with a formula, but some people they'll know, I know what I need, PRN.
Yeah. That's, and the other thing, most of the people I've worked with, so usually when low-dose naltrexone is prescribed, they'll be prescribed 1.5 milligrams. Take that for 2 weeks, then bump it up, and okay, 2 weeks later, and at that rate, it's going to take 2 or 3 months to get to the 0.06 milligram level. And if the person isn't really dealing with more serious medical issues, my experience is they don't need to wait that long. Most of my clients ramp up to the full 0.06 milligrams per kilogram ratio in a week or less, or two. Basically, 2 days to 2 weeks.
Yeah.
Some
You were
people,
the fastest I've ever heard. When you told me that, I went, but because it usually is, you guys, 1.5 for like 2 weeks, then they go to 3, then they go to 4.5. And that takes, they do quite a bit, because you can have a little bit of discomfort and weird getting used to the feeling of it, maybe a little loose stool, a little bit of headaches. The worst is usually sleeplessness, believe it or not, headaches, and maybe some diarrhea. Diarrhea seems to be the one that most of my patients will sometimes go through. I'm like, wow, it's really interesting. But when you said that to me, you said, no, Stephanie, you can't go slow. These people are in like mental crises for the most part. I don't have time to waste with trauma, with PTSD, let's get them there quickly, which was really, which was to me.
If they're medically fragile, you do want to go slow, but if they're not medically fragile, and certain disorders respond better to a higher dose. There's a Norwegian protocol that starts the way you described normally starting out, but if they're not responding right, they bump it up to 6 milligrams or so. And they're doing that, I think, basically to address high inflammation in the system. So you're trying to disrupt that inflammation. And and if that's the issue, then you want to get it up there. I had a client who had familial cold-induced inflammation disorder. So if she was standing in front of the freezer door at the supermarket, opened it, got a flash of the cold, she could be in bed with swollen joints, a fever for 2 or 3 days. Low-dose naltrexone, her sweet spot, if I recall right, was 10 milligrams, taken 2 to 3 times a day. But this is dealing with an inflammation disorder. But she also had PTSD, pretty severe case of PTSD, both childhood and relational. But nothing else touched it like low-dose naltrexone did.
Wow, that's so fascinating. I mean, it's like, can you imagine the change in that woman's life? Oh, what a weird, bizarre, difficult thing to deal with. Nobody's going to understand that. You have to deal with this in life, going through, and it makes total sense.
Yeah, she had a great boss. He was very supportive, but she was missing work on a regular basis because of the PTSD or because of the inflammation. She had far fewer flares. Yeah. PTSD stopped being a problem for her.
Well, it makes sense. She's more susceptible to PTSD. Like we have genetic markers. People have 3 times as much cortisol. They're much more, susceptible. And that, interestingly, bizarre genetic, condition would prime you for more inflammation, which is priming you for more cortisol, priming you for more set hold in the brain. Makes total sense.
Let me talk about just a little bit about the theory of why it's helpful, especially with PTSD, especially with complex PTSD and early attachment, childhood issues. So we're trying to unpack it. It's a key factor is to consider that neurodevelopmentally, when children develop and they're exposed to persistent neglect and abuse, it alters how the opioid system develops. And what happens in certain key areas of the brain, at baseline, you make fewer opioid receptors. So you've got a narrow response range. So if you have more opioid receptors, it's going to take more opiates binding with those receptors to get a person to dissociate. But if you've got a much narrower range of response, so those receptors can get filled up sooner, and then you're dissociating. You're just not there. So with low-dose naltrexone, it causes an upregulation of opioid receptors and opiates, endorphins, and other kinds of opiates. So you have a wider response range. A lot of the information online talks about increasing endorphins. They usually don't talk about increasing endorphin receptors for the mental health benefit. It's probably more about increasing the receptors than it is just about the endorphins. And it is cool. It does increase endorphins, but it does so much more. That is just the tip of the iceberg as far as what it does. It affects just about everything. So you do this, so you have this restricted emotional response range when you encounter something that represents threat to you. Could be an argument, could be a smell, who knows what it is. So you can more just quickly default into this dissociative response. So basically the default setting gets set to threat mode. And naltrexone.
The longer this goes on, right? So people understand, like when kids are being raised, and it's like you're developmentally changing the structure of how things, the amount of receptors and how everything is made. So now they're primed, is what you're saying, like to be way more sensitive, way more reactive, and what we would say is less resilient, or, you know, not able to tolerate discomfort, and then have to check out, trance, dissociate, whatever, to survive it, because the receptor area is smaller and gets flooded very quickly, right? Okay.
Yeah, and so the trauma survivor gets at least a double benefit from naltrexone. They get the benefit of reduced inflammation, which goes along with the trauma, and then they're able to stay present instead of dissociating. And naltrexone works the opposite way virtually all other medications prescribed for mental health issues work. Most of those kind of blunt down emotions. And in some cases, that's helpful. But in a lot of cases, a lot of people have told me, well, yeah, my medication, my antidepressant, okay, I don't feel as bad, but I don't care as much. I don't feel, I never get to feel as good.
Yeah. And they lose sexual desire often as well. And they're like, that's not, I'm not happy about that part, right? Yeah, there's a lot of other,
Naltrexone does the opposite. So it causes you to have your feelings more fully. And usually that's a good thing. Now, if you've been dissociating your whole life and you start taking low dose naltrexone, well, all of a sudden, you're going to be feeling your feelings more. And the good thing of feeling your feelings more might feel like a side effect, a negative side effect, because this is a little overwhelming to be present instead of dissociated a lot of the time. So it's really important to know that that's a possible effect of it. And it takes some time to adjust to it. And if
probably why having a therapist and working and while they're teaching you skills and teaching you to be aware of this and how to manage that was probably
there really needs to be some psychoeducation, or at least the individual needs to do some education. And we talk about that in the chapter in the LDN book, the volume 2 of that. But so if you've got a more extreme history of neglect, then you may well also be dealing with a phobia of shared positive affect. So what that looks like is, hey, you look great today, Stephanie. How are you doing? It's just so good to see you. And I really appreciated how you showed up in the meeting the other day. And pretty soon, if you've got a phobia of shared positive affect, you're just thinking, get away from me. This is creeping me out. And there's my experience is virtually everyone that I've worked with in the recovery community has some version of phobia positive affect. Someone says something nice, and it's like, okay, if they're a quick study, then they go, yeah, thank you, and hope they go away. If you're not such a quick study, you deny it, You say, oh, this haircut, this looks terrible. Yeah. And what happens then? No, the person goes, oh no, you look really good.
They make it worse.
Yeah. I had a woman I was working with her. She told me the story. She'd been working on it. And her partner said, oh yeah, you look really nice in that sweater. Her response was, oh, I was going to give it to the Goodwill. Got to deflect it, make it go away. Yeah. So if you've got any kind of phobia, positive affect, you want to know that you're going to feel your feelings a bit more. It's good to feel positive feelings. It's really the current of human relationships.
Yeah.
Currency of human relationships. But you may have been protecting yourself from feeling it your whole life. So you've got to gradually learn to take it in. And I teach people to expose themselves, to allow it to be there and feel it as much as they can. Yeah. If you've been deflecting it your whole life, you can't gulp it down. It's just going to freak you out.
Yeah. Yeah. That's where, working with a trained, therapist like you and people who are, that's why I love to leverage the neurotherapies that are types of therapies that are accessing the brain, such as, let's say, EMDR or various types of neurofeedback that can help make this process even faster, along with talk and having them rethink, their ways of thinking, cognitively in addition to it. So you're kind of unhooking it in many ways, going after the receptors and the opioids and neurological. And let's actually talk about it and get used to comfortable. Wow, you can actually feel happy and good, Yeah, it's a fascinating journey.
It's a real mind bender. The idea that positive feelings don't feel positive.
Yeah. I've seen it on HRV. Do you do like heart rate variability with your clients? Do you do that too?
I know about it. I haven't integrated it as
okay.
much as I should.
Well, it's fascinating because if you started using it, it doesn't take a lot. I have seen many of these type of dissociative clients that have that. They're upside down reversed. Like if they feel bad feelings and remember a trauma, they'll actually increase their heart rate variability, which is what you would want. Mm-hmm. And if they try to feel love or compassion, to think about their pet or something, it actually gets worse. They're like, look, and we can do it. And it was kind of stunning to me, 15 years ago when I was seeing this. I think, how is that possible? How is what I'm seeing in front of me? But it's because of that, like the discomfort is more comfortable to them, and they've created their whole physiology based on
literally uncomfortable. Yeah, it's literally uncomfortable. And this is not, I don't know if you're hearing anywhere in graduate school, you hear about phobia, positive affect. There's a lot of talk about people have trust issues, but it's not talked about as a phobia. It's really useful to think of it as just a regular phobia. And phobias are self-reinforcing. So if you aren't dealing with the phobia itself, it's just going to stay strong or get stronger. It actually changes pretty rapidly if you're working directly on it. That's just basic exposure. Noticing is positive. I have people come back later and imagine the experience if they just automatically deflected it, which people are doing all the time.
Yeah.
But I think it's a really powerful concept, and you're not going to find much on the internet on it or anywhere.
Yeah.
I certainly didn't get in graduate school.
So let's talk about this. I like to leave people with useful things.
Yeah.
And this is a little bit of a tough one to find therapists that know about LDN for doing it this way. Now, what we just taught people, they'll probably end up knowing more than their prescribing physician about it at this point.
A decent chance.
Yeah, and they'll probably know more about LDN and mental health than their talk therapist. Okay, so how do we help the person out there listening? Like, how do I get some of this, or what should I do? What's your best piece of advice? Because you can't see everybody. Like, we will drop his information below, you guys. He's in Eugene, Oregon. He does see people in person and virtual, but I know he's very busy, and that's
So,
on you.
okay,
But what can they do? How can we
the
help?
first hint would be in the therapy world, you're more likely to find someone knowledgeable in the EMDR world. And that's because Ulrich Lanius is an EMDR therapist, trainer, and he's presented in the EMDR community multiple times. So if you're looking for a therapist that knows something about it, the odds are better you'll find someone that knows about it there.
Okay.
And I'll provide you with a bibliography with Ulrich's, the neurobiology of dissociation. That's not going to be for the average reader partly because it's a $100 book, but it's really for clinicians.
Okay.
But chapter 22 talks about naltrexone, and that's a good source. Naturopaths are usually far more knowledgeable about this. They have experience, but they don't have experience using it for mental health issues.
Right.
And so reading what we referenced earlier would be helpful. So what generally, if you're going to a prescriber that doesn't know anything about it, you've got to do some homework.
Yeah.
Some of the studies, there's virtually no research on low dose. There's two papers on low dose. One is a combination of very low dose, not extreme low, but just 1 milligram or so combined with antidepressant that showed it was helpful. Because one of the things that, and this is important, is that low dose naltrexone makes some other medications more bioavailable. That is, you get more bang for the buck. So if you're taking a medication that needs to be adjusted for its presence in blood level, naltrexone can increase or decrease the need for taking, you may need less. And so that's important. And you can have if you're like on an antipsychotic that has side effects, you start taking low dose naltrexone, well, maybe it makes that antipsychotic more potent. Now you're having side effects. It's not naltrexone.
Yeah.
You've got to lower the antipsychotic.
Yeah. Same thing happens with neurofeedback, right? I tell people, you start regulating your brain, you're going to start eventually having more side effects from the drugs. It's not the neurofeedback. It's like you're getting regulated. We have to titrate. That's what happens as you heal. It's fascinating. So yeah, LDN, I forgot that it helps basically attenuate other medications as well.
Yeah.
This is why, having somebody so in the perfect world, we just get more therapists and psychiatrists and people learning about LDN, and we get a lot more competence. And why many of them don't, you guys, is because it's off patent. Pharma is not going to fund studies on it. It's not profitable enough. So unless you have a bunch of studies and that pharma reps are going in and selling to the prescribers, they don't know about it. And Rockefeller kind of, psychiatrists and physicians are kind of used to, well, I should see like a bunch of studies, right? A bunch of studies.
Right. They want the random control trials, and we don't have random control trials. We've got one series of case studies on dissociative patients, hospital dissociative patients, Vitka Papa. And that's most of the studies of naltrexone are not fully controlled. They may be randomized, they may be open label, they're not the highest quality because it's really expensive to do that.
Right. No one's going to fund it. That's the problem. I mean, that's what we're down to.
Yeah. And it's going to compete with other things. So it's not standard of care, but there's one really important factor here that makes it attractive is there is literally nothing that the doctor can prescribe that is safer than low-dose naltrexone. Probably literally everything they would prescribe probably has a greater risk than naltrexone. The study by Bolton, it's a meta-analysis of over 11,000 people. And what they got in that study was out of 11,000 people, there were 6, negative events, none of them serious.
Wow.
So we're talking about, a negative medical event, but it's a low grade medical event. So it's about 1 in 2,000. I mean, aspirin's more dangerous than that.
Right.
I had
People
a
don't know that,
client
yeah.
who thought her doctor thought she was having an allergic reaction to naltrexone. It actually was aspirin.
Yeah.
This particular client, she was the first client I had take low-dose naltrexone, extreme trauma, very sleep deprived. The first time she took it, it was like taking a tranquilizer the first week or so. And that's because it put her in touch with her sleep deprivation. It would just knock her out 20 minutes after she took it. After her body adjusted to it, she got a little sleep. She would, it didn't knock her out in the same way. Same person would talk about, she would have the thoughts that she would normally ruminate on come up, but she couldn't keep focusing on it. She didn't need to, she'd put them in perspective, and it's just, I don't need to keep thinking about that. She was still very anxious. She still had a lot of trauma to deal with, but she didn't get stuck. Same with OCD. It makes it easier to let go. And pretty much everything mental health, it just makes it easier.
I think I love that you added that. Thank you about the safety profile, because that's always a major concern with people in the psychiatric, drug realm, that they aren't as safe. And that's just a reality. And I'm just saying, like, everybody's got to do what they got to do to help themselves. So I'm not saying not to be on your medications. I'm not saying any of that. I'm just saying, here's another option, another class, something you are not hearing about. And so to me, the more people learn, go to that website, print things off, say, hey, I listened to some podcasts, I listened to some webinars, I've done some research. Do you know about this? Or try to find an EMDR, trained person that does know about it. I think the more people do that, I learned about it because of all the patients that were coming in my office on it. That is the truth. That's simply, I was like, I've got to learn. I've seen this again and again, and they all say good things. They all say, oh, it's helped so much with my shoulder. Oh, I'm on it. I'm getting it from Europe. It was from the cancer. I'm getting it. And I went, and eventually I just had to research it. And I went, wait, this looks pretty good. And I see it. I've seen before my eyes, positive response after positive response. And again, that was for the autoimmune type things I see. And I go, a lot would come in and say, I went to my doctor, they prescribed all this stuff, I just want you to double check. I'm like, no, that actually, and they go, I don't want to take all these drugs. I gotcha. Oh no, LDN, that's great. Your doctor, and I look and like, your doctor knows what they're doing. They have you on the right thyroid stuff. They're trying to help. Like, this is great. Let me help you with the tweaks that I can suggest, and take it back to your doctor. And so I like to work in partnership. Like, they have their strong suit and I have my strong suit. So LDN is one of these things, you guys, in the mental health landscape that is not being utilized to the lengths it should be. And with the whole COVID stuff for the last few years, it's kind of come up stronger for me. I'm like, wait, this is a brilliant immune system modulator. This helps deal with these cytokine storms. Why is no one talking about this? And sure enough, everybody in my practice that's on this and been on this, they never get sick.
I don't take antihistamines on a regular basis anymore. I used to take them 6 to 8 months out of the year, because I live in the Willamette Valley, the pit of the Willamette Valley, grass seed capital of the world, essentially. I'm taking low-dose naltrexone, and it means I don't have to take antihistamines like I used to. On what you were saying, there's February 2022, a theory piece in European Heart and Cardiovascular Pharmacology, repurposing low-dose naltrexone for the prevention and treatment of immunothrombosis in COVID-19.
Yeah.
There's a study on similarly, theoretically saying treating stroke with naltrexone. And we didn't talk about traumatic brain injury, and it can be helpful with brain fog. Mm-hmm. And with traumatic brain injury, if it's a fairly recent injury, it probably needs high dose naltrexone. And the US has ignored the study for the most part that's been done of using.
So like high dose, like 50 to 100, like that type of?
Yeah, or up to 150 or so.
Oh.
Already had a patient who, when she was operating in the lower 10 percentile after a brain injury, got her on high dose naltrexone. She was on it for close to 6 months, I think. I had a client with a traumatic brain injury. Low dose didn't help that much. We took him up to 50 milligrams and he was it really evened things out for him. A lot less brain fog, less anxiety. And then eventually went down to low dose after a few months. The Chinese have done good studies on using opiate antagonists. And there's a really good 2014 meta-analysis on using naloxone for acute traumatic brain injury. Every single domain affected by TBI is benefits from an opiate antagonist.
Wow, it's incredible.
It really is. It's just the power of the influence of greed and making money to keep something from being.
Yeah, I agree. I mean, because I tell you, I have a whole stack of what I would want. I'm like, well, I kind of joke with people. I'm like, this is what, if I get knocked unconscious and I'm in a hospital, these are the things I need you to come and do. I need you to do this and tell them you better put them, and I want you to do neurofeedback while I'm there. I want ketones. And now I'm going to say, make sure I have LDN, because I didn't know about that.
This is probably the most exciting thing and I don't think I had this when I talked to you last, but there's an Egyptian series of case studies of 5 children, the effects of low dose naltrexone on intractable epilepsy.
Wow.
And every one of these children, so they were not responding to the medications, standard medications, they responded to low dose naltrexone. Really exciting study.
That is exciting. Yeah.
Yeah, because it's
super safe.
It quiets down inflammation. It quiets down autoimmune kind of reactions that happen when you get banged on the head. Now you've got brain material floating around and your immune system reacts to it. Naltrexone quiets that down.
Oh, brilliant. Well, I hope you guys, are hearing, again, it does a lot of things, but there's some brilliant other videos. I'll drop a video down here. It's a Dr. Bean. I like this guy's immune modulation video of it. So there's that, because we've talked a lot about that. You might be like, wow, that sounds like it does so much. It does. I'm going to put that in there as well, because it's one of my favorite videos that I use to show patients to explain its power. And I will tell you, I've converted many like a patient's grandfather. I got one right now, a kid is a teenager, and it's helping with his anxiety. The family and everybody is so happy. The grandfather's a retired pathologist, and he just thinks almost everything I say is woo-woo, bizarre, and why does diet matter, and what is this weird neurofeedback stuff? But I made the suggestion, and the psychiatrist agrees, like, you know what, that's an interesting idea, and he did it, and the whole school is super happy. And and it was to avoid methamphetamine. They wanted to give him an ADHD drug. I said, can we do something else? Can we try something else? Because I'm working on this inflammation problem. Okay, I'm working on something else, trying to help heal the gut and all the things that are going on. And now the pathologist is utterly mind blown, and he's like, the family's reached out. He's like, so it looks like everybody in the whole family should be on this stuff is how, and he's mind blown. He's like, how do I not know about this? Yeah. And so I love it, because now I get this guy in my back pocket, and he's going to influence a whole bunch of practicing physicians and the whole family, which is like, there you go. I don't have to do anything else.
How do you not know about it? Is you only do standard of care. And so you'll never be cutting edge. Couple more things. Borderline personality disorder. There's a recent German study. This is high dose. And they conclude that naltrexone appears to be the only psychotropic medication that benefits borderline personality disorder. This was a population study looking back at their patients, but nothing else had a statistically beneficial effect on the patients they were discharging.
Which makes total sense, because that to me is kind of like a developmental PTSD
Oh,
kind
yeah.
of conglomerate diagnosis anyway. It's a very tough, I've worked with a lot of them, and it's a very difficult
Very difficult,
condition for
and
them to live with. Yeah.
none of the conventional medications
Yeah.
really
It's
significantly
tough.
affect it, but naltrexone does. Now, in that study, it was higher. The higher the dose, the more benefit. And
Okay.
I'm
Was that
guessing,
multiple times a day as well?
well, that was 50 to 100 milligrams. I think it was 25
So-
to 100 milligrams.
Okay, so one big,
Yeah, they didn't have a low dose category.
okay.
But the other thing, we'd be remiss if we didn't just mention that low-dose naltrexone works for fertility
Mhm.
and is amazing for PMS.
Yep, PCOS,
PMD.
all that stuff. Mhm.
Yeah.
Yeah. I have a lot of, that's what I was leveraging it a lot for. And there's a lot of depression and mood swings that go with that. And it's a way I can go in there and help heal the hormonal disruptions of, and then I go in, I work on their insulin resistance and their diet and all that other stuff. But to give that relief and help the system modulate all that inflammation is extraordinary. Yeah, the fertility is fascinating. I don't work on fertility, but what people go through to
Yeah.
get pregnant now, and it can have a tremendous amount of stress and strain, in a relationship.
Have you looked at Dr. Boyle's?
I have, yeah.
That's very cool. And no negative effects on the mother or child
Right.
if you stay on it.
Yeah, I find that really interesting when you're talking about like the kids. I was thinking about with childhood trauma and ending up with much less receptors, so much easier to be flooded and dissociate. I was like, I wonder, like with women who are pregnant that are taking it low dose because they needed it to get pregnant and they need to stay on it for whatever condition, how that will cause. It would postulate, you could think theoretically there'd be a positive impact in terms of the amount of receptors that are made, in the child, but I don't know.
Potentially, and when Dr. Boyle did follow, half the women stayed on and half stayed off, there was literally no difference in mother or child throughout the course of the pregnancy and the outcome of the birth. If anything, trending a little better on low dose, but nothing statistically different.
Yeah, it'd be interesting to see, like if they came across trauma and what the PTSD rates would be on those children 30 years from now, right?
Yeah.
That were on, and parents were on it, mother was on it and breastfed on it or whatever, and then kids that didn't.
We're thinking about epigenetic changes. So is this altering epigenetic changes?
Right. I don't know. It's fascinating.
Very.
Right? That'll be the kind of meta, analysis that somebody's going to do eventually. Not me, not my world, but I.
It'll be a ways.
Yeah, it will be.
No, I think someday this will be part of standard of care, but that's probably not going to start in the United States.
No, I foresee it being over the counter. I mean, I do eventually, but if things change, I mean, you can go to other countries and what you can get over the counter in Turkey and over the counter in Mexico, and what we go through here, it's like, wow, it's really, really fascinating. So on that note, we've been talking a while. I want to value your time and let you get back to, is there anything else you want to add to the listener? Any final note? And I hope, Galyn, you're going to give me, so these studies you've mentioned, are we going to have like a link to these or the bibliography?
I'll give you I'll give you a link, or I'll give you a citation. I'll give you whatever information.
Okay, perfect. You guys, so everything he's mentioned, so you're not overwhelmed, you want to read yourself, for all of you, or take them to your doctor, take them to your therapist. I mean, imagine if we had more and more, therapists like you understanding this and working together. I'm all about, I think healthcare should be much more holistic, much more integrative. And if everybody one person doesn't have to know everything, but if 2 or 3 of us could work together as a team for you, you get much better, much faster. And because I have to tell you, I work with a ketamine psychiatrist. He was actually a patient of mine.
Oh, yeah.
And now he came for neurofeedback, and now he does ketamine assisted psychotherapy. It's not what he was a researcher when he started with me. Life has completely changed. It's more of who he is, and does ceremonies with it, and like shamanic journeys, very strong set and setting. And he's one of my go-tos, like, okay, well, how much LDN? He's like, I don't know it that much, but I'm willing to learn. So can like, that's very different when I can send to, Dr. Thomas, he's going to do ketamine therapy with you. He'll determine if you're a candidate. I'll still do this part, and we can communicate about you so we can best support you. Imagine that.
Yeah. It's great.
We're not fighting or competing. We're working together to help you.
Yeah. That's what we all want.
Yeah.
It's a team working on our behalf, working with us. Yeah. And ketamine's great.
Yeah. And I don't have to learn all the drugs. I don't want to. I'm like, you do that part for me, and I do this part. And what do you think about this? And we can have those conversations. I work with physicians and say, well, I'm thinking maybe LDN. He's, oh, that's a great idea. Maybe I'll do that. Okay. And he says, well, I think I should do this other drug. I'm like, okay, if you think so, like, cause a little bit better, like that's how it should be. And if your doctor isn't like that, you guys, I suggest you find somebody else. Cause
Yep. You do want to do that. There is one or two other things I was noticing. Which is there are side effects when you start up. Not everyone experiences side effects, but some people do. And the side effects are going to be maybe a little upset stomach, more vivid dreams, maybe is the most vivid.
Oh yeah, that's a big one.
I think that's the most common side effect, but it's rare that they be bad dreams. It's mostly they're just way more vivid, partly probably because now you're getting into REM sleep and you weren't getting into REM sleep before. So you're having more dreams. It's going to even out after a couple weeks.
Yeah.
After your opioid system, your immune system starts quieting down and gets used to having it on board. A small number of people get a mild headache. What else? I've had one person.
Sleeplessness is one. I find half the people kind of trouble sleeping it a little, and they take it then in the morning or whatever, and then eventually it all works out. But yeah.
Yeah, and that not sleeping generally, I think that's related to getting some energy from it. Yeah. You're not getting wound up, but you're getting energy from it. It's also important to note you can drink alcohol on it. It's not a problem. You will relax a bit more having alcohol, but you're not going to get a buzz. I had one young man, it really helped him in many ways, but he really wanted the buzz. So he wasn't Naltrexone. This was a college student. So
well, let me say this. You could take a low dose. Let's say you took 4 milligrams. If you took it in the morning and you drank at night, you'll get a buzz that night.
Yeah, you will.
It's like if you took it at the same time, you're not going to get that.
Right.
Yeah. Okay.
And another really interesting area is the Sinclair method, which is different than the way high dose is used in the United States. The Sinclair method, you take 50 milligrams and you have to drink alcohol. This is for alcoholics.
Oh, okay. I'm like, what is this?
Alcoholics.
Okay.
And this is the more effective way to use naltrexone to treat alcohol addiction. Instead of just knocking down urges, you take it and then you drink. So what happens is you drink in moderation because you don't feel like drinking more. And you do that over and over and over. This is like reversing Pavlov's dogs. You ring the bell, pretty soon they're slobbering.
Right.
And nobody talks about, well, Pavlov also reversed the conditioning so that, now the dogs aren't slobbering when they hear a bell because they weren't getting fed enough times.
Wow.
Sinclair method, Dr. Sinclair in Finland developed it. And then when they joined the EU, Finland stopped using the Sinclair method, apparently.
Oh.
But it works. There's a really good documentary on that. I think it's called One Little Pill, but, of an actress who she was headed to an early grave. She'd done a dozen different programs, nothing worked.
So they're doing it, but they're never getting a buzz, and then eventually they like titrate them off or something. Like they're like, I don't even want it. It's not even good anymore. It's gross. What happens?
They're not chasing the alcohol solution anymore.
Wow.
And they can drink if they've got it on board. You know, if someone really wants the buzz, they could try and override it and maybe get alcohol poisoning, but they're just not going to feel like it.
Right. Wow, that's really cool.
Yeah, it's well, I haven't told very many stories. There's a lot. I've worked with about.
Well, end on a story. Do that. How about you end on a story?
Okay, I've worked with about 80 people. What would be? So, that's hard. Okay, yeah. So, and this brings up anger too. Working with a Vietnam vet, he started, and the first time I met this guy over the phone, he had an anger storm with his girlfriend. And, so that was a big deal. So this quieted his anger down. He started on 2 milligrams, and that was really helpful to him, though his target dose was 4. Somehow I dropped the ball and didn't track it close enough. So he went a year or so at 2 milligrams, getting a benefit. And then I discovered, oh, you're only taking 2 milligrams. Let's bump it up. This is a really interesting guy. He played pool. He was really good, but he always choked when it came to when he got in the finals. So he bumped it up to 4 milligrams. And I got a call at home. It was like a come to Jesus call. This is like a whole nother low dose naltrexone experience. Instead of choking, he's just cold as ice. He wins tournaments instead of choking at the end. It's probably responsible for him eventually marrying the woman he married. I think of another woman who, she always had a meltdown around PMS times, and she attributed it getting married eventually to low dose naltrexone. It's easy to stop taking. So because it's so subtle, you're not addicted to it like all your antidepressants. You don't get addicted to it. I don't know if you get addicted to Wellbutrin, but so you don't get addicted to it. So you can just be doing all right. And then what happens, they come into my office and we talk about things, and things are just gone south and not doing so well. I'm not so happy. And it's like, oh yeah, you still taking naltrexone? Oh, no. Oh, when did you stop? Oh, about the time everything went south. And so it's like, it's kind of invisible once you get used to it. Also, I don't expect that it's going to change your biological baseline. Maybe it does if you take it a few years, but it's just going to help you, that baseline of having more receptors all the time. Your body is constantly creating new receptors and sloughing old receptors off. And so you're going to need to keep taking it to get the same benefit. But people get to the point where, no, I'm stable enough. I no longer have PTSD. I've worked in therapy. And so you don't have to keep taking it forever. But it's easy to forget.
Yeah, that's a thing people do want to always ask, do I have to just take it forever? And again, it does depend on what you're trying to do with it. What is your goal with it? What is it being used for? So, and many people decide my quality of life is so much better, especially say something like progressive MS. And
you will need to take it forever, and you can, it looks like, safely take it forever. You know, we don't have the research that says that, but there's no indication that there's any toxicity. One other thing too. So taking it for mental health, taking it multiple times a day, I haven't seen any anecdotal evidence in my experience that it compromises getting the benefit for immune system issues. So I think of a client of mine with Ehlers-Danlos which
So,
helped
yeah.
with her hyperflexibility, pretty much got rid of the diverticulitis. Didn't get rid of it all, but it's so much better. But I haven't seen any indication that taking it multiple times a day undermines the other autoimmune treatment.
Okay, the immune boosting effects aren't decreased by taking it multiple times a day.
I have
for
not
mental
seen
health
evidence of that.
issues. Okay,
The exception would be if someone's treating you for cancer, you may want to just take it one time a day. We don't know. No one's done the research there. And with a cancer, intermittent use is a significant part of the benefit. But that intermittent use can be taken at once a day. That's also necessary to get any benefit for cancer with cannabis. You've got to take it intermittently, not every day.
Okay, interesting. Yeah, well, we won't get into cannabis too much, but I pretty much use a lot of CBD oil. I'm here in Georgia, and cannabis and CBD and LDN work very well together. There's a ton, you guys, of pharmacologists doing whole webinars on this all over YouTube. I mean, it's pretty extraordinary how these two, they're both modulators. You know, you have an endocannabinoid modulator, which is an inflammation modulator, and then you have basically an immune system modulator and the opioid modulator, and how they work together. So I almost always want my clients on both.
Yeah,
you know, at the
they
same
work
time.
together.
Yeah. So I pretty much always say that. I'm like, look, just trust me. You know, I explain the science. I'm like, if you could just do them at the same time, we're going to get there a whole lot faster, and you're going to feel a whole lot better, you know? Yep. All right. On that note, we've been talking a long time. It's been awesome. We'll have all the information in the description for you guys. It's right down there. And, you know, Galyn, thank you so much. And thank you so much for what you're doing. You know, the mental health field is tough and rewarding and difficult. And it's just the up and down. And it takes a lot to hold the space for people that are so overwhelmed, terrified that they don't feel like there's any hope. And to be able to stand there and help guide them so they can find hope again is no small feat. So,
and for some people, this is a total game changer. There are people that I don't know what I would do without EMDR, and sometimes I'd say the same for low-dose Naltrexone. Sometimes it's a game changer.
Well, there you go, you guys. Please, I hope you heard this whole YouTube, you know, coming at you, that there is hope. I'll have everything down below. I do not prescribe. Galyn does not prescribe, but we both do offer support in the mental health fields. All our information is down there, and we can help get you the care you need in a holistic manner if you can't find it on your own. Okay. Thank you so much.